All right, welcome to this series on pharmacology. There will be 4 lectures on pharmacology today up to Friday. Today, we're going to deal with cardiovascular drugs because this is one of the most common drugs that you will see in NCLEX. The reason being that cardiovascular problems is going to be a #1 problem here in the United States. So, included in the discussion today are discussions on drugs affecting the renin-angiotensin-aldosterone system, beta blockers, calcium channel blockers, and that should be it. All right, so let's begin with understanding what blood pressure is. We all know that blood pressure is determined by the product of cardiac output and systemic vascular resistance. We talked about that the other day. And numerous factors interact with these 2 major variables to keep the blood pressure within normal limits. And I think that one of the confusion that arises nowadays is that nurses still have not adapted to or have become familiar with the new standards as far as normal blood pressure is concerned. As you can see, the normal blood pressure, according to the 2017 definition of normal blood pressure, is going to be a systolic of less than 120 and a diastolic of less than 80. And note now that elevated blood pressure is now considered to be a systolic of 120 to 129 and a diastolic of 80. So if your blood pressure is 130, that is now considered to be a high blood pressure. So let's make sure that we are familiar with this new definition of what high blood pressure is and what normal blood pressure is. So in dealing with blood pressure, we have a lot of categories for therapy for hypertension, and they include your ACE inhibitors, your angiotensin receptor blockers or ARBs, your alpha blockers, your beta blockers, your calcium channel blockers, and of course, diuretics. So we will talk about most of these in the next slides to follow. All right, so let's begin with a discussion of renin-angiotensin-aldosterone system to provide the mechanism of action of 2 drug types we will be discussing, which are the ACE inhibitors and the ARBs. So I'm going to darken the slide now, or the screen, because I'm going to use it to write, and I'm going to discuss a little bit about the renin-angiotensin-aldosterone system. So the renin-angiotensin system actually works because the stimuli that actually facilitates its onset is going to be a blood pressure that's going to be too low. So when the blood pressure is going to be too low, what's going to happen is that the kidneys are going to sense it, and in particular, the JG cells are going to sense this decrease in perfusion, and they release a substance, and this substance is what is known as renin. So remember that renin was stimulated as a result of the sympathetic nervous system response. Now, with renin present in the circulation, it will activate a substance in the liver. And this substance in the liver is what is called angiotensinogen. This angiotensinogen causes it to turn into angiotensin 1. With this substance present in the vessels, it will cause an enzyme to be activated. And this enzyme is called ACE, or angiotensin converting enzyme. It converts angiotensin 1 to angiotensin 2. So going back again, whenever there is a decrease in blood pressure, the JG cells respond. They secrete renin, and this renin activates angiotensinogen in the liver, which also is going to become involved in the formation of angiotensin 1. And angiotensin 1 will now be converted to angiotensin 2 in the effect of angiotensin converting enzyme. So the way that angiotensin 2 forms is because of the effect of angiotensin converting enzyme. All right, whenever angiotensin 2 has formed, it will now cause several reactions. And one of the most significant reactions that's going to happen is that angiotensin 2 causes vasoconstriction. So we all know that when vessels are vasoconstricted, what is the result on BP? Well, they increase the blood pressure. So the initial decrease in blood pressure is now going to be solved by the release of renin, angiotensin, and aldosterone. Now, in addition to that, angiotensin 2, the presence of angiotensin 2 will now stimulate the adrenal cortex, and the adrenal cortex will be stimulated to release a substance, and this substance is what is called aldosterone. Now, aldosterone is something that will cause the kidneys to keep sodium. So kidneys keep sodium. And if it keeps sodium, it will also keep water. And so the volume is going to go up, therefore, and therefore this also causes an increase in blood pressure. Now, one thing that is important as far as the action of aldosterone is concerned is that it also is going to excrete potassium. All right, so these are all important because we're going to find out whenever we alter these things that something happens to the blood pressure. So there's one thing that we can do, therefore, an example of that is if we stop ACE from acting, we therefore are not going to have angiotensin 2. And so these drugs that stop the ACE from converting angiotensin 1 to angiotensin 2 are called your ACE inhibitors. So this is where they work. All right. Well, there are other kinds of drugs that are going to alter or interrupt the increase in blood pressure. And the other drug is anything that blocks angiotensin 2. And these are called ARBs. It stands for angiotensin receptor blockers. So by looking at this particular sketch and map, you now understand how these ACE inhibitors and angiotensin 2 receptor blockers is going to help blood pressure or hypertension. So this, in essence, is the renin-angiotensin-aldosterone system. So remember that angiotensin 2 causes vasoconstriction, and it also causes the release of aldosterone from the adrenal cortex, and therefore it increases blood pressure by increasing volume. And the way it does that is it reabsorbs sodium, and it also reabsorbs water. Whenever we do that, however, there's going to be potassium excretion. So that is the renin-angiotensin-aldosterone system as a very brief discussion. And so let's see if we did not get confused with that explanation. So the question here is, angiotensin converting enzyme, or ACE, performs what role in the body? So does it inactivate bradykinin? Does it dilate blood vessels? Does it cause the kidney to keep sodium and water? And does it convert angiotensin 1 to angiotensin 2? Okay, so don't be afraid to answer, Jan. I know you're the only one, but this is an exercise for you. All right. So you said that it converts angiotensin 1 to angiotensin 2. Very good. ACE is the enzyme that actually facilitates the conversion of angiotensin 1 to angiotensin 2. Very good. Okay, so let's go to the next question. Hold on one moment. I think, yeah. Okay. It's not launching. Okay, I don't know why it's not launching, but the correct answer is aldosterone and vasoconstriction and aldosterone. Letter C, you are correct. All right, great. So let's move on. So the first drug that we're going to talk about is ACE inhibitors or angiotensin converting enzyme inhibitors. And let's take a look at how ACE inhibitors work in the body and what the indications are, as well as the contraindications are. Now, what I'd like for you to do is to remember the suffix of this drug. Anytime you hear pril, it is going to be an ACE inhibitor. So examples of ACE inhibitors would be your enalapril, lisinopril, ramipril, benazepril, and captopril. So all these ACE inhibitors for short are a group of medications that help decrease blood pressure and are typically used for the management of patients with hypertension or heart failure. But they could also be administered to patients who have recently had a myocardial infarction. So most of these medications are taken orally, but there's one ACE inhibitor called enalapril that can be administered intravenously for hypertension or severe heart failure. But I'm not going to dwell with that a lot because that's a critical care drug, and therefore it's not likely to come out in the NCLEX. Okay, so let's take a look at the mode of action or the mechanism of action of ACE inhibitors. So if you remember that the ACE inhibitors are going to stop the conversion of angiotensin 1 to angiotensin 2. And interestingly enough, these ACE inhibitors work or are secreted in the lungs. And thus, what happens, therefore, if this occurs in the lungs, if you inhibit it, there's going to be one symptom that you should not forget, or the side effect that you should not forget whenever there is a patient getting ACE inhibitors, and that is a non-productive cough. Okay, so if you take a look at this, we do not convert angiotensin 1 to angiotensin 2, therefore we're not going to have vasoconstriction, we're not going to have aldosterone production, and we're not going to have salt and water retention. So therefore, this is a very effective anti-hypertensive drug. Okay. I don't know why these are not launching, but anyway. Okay. All right, which statements correctly describe how ACE inhibitors work, and select all that apply? Okay, so let's see what the correct answer is. The correct answer is letter A. It inhibits the renin-angiotensin-aldosterone system. So that is correct. So let me just indicate the answer here so that we will not forget it. And letter B prevents conversion of angiotensin 1 to angiotensin 2, which is also a correct response. So A and B are correct. Prevent angiotensinogen. Well, this is incorrect because angiotensinogen is the one that produces or activates angiotensin 1, actually. And letter D exerts a positive chronotropic and negative inotropic effect on the heart. So positive chronotropic, meaning to say that it is going to increase the force of contraction. That's what positive chronotropy is. And negative inotropic effect, sorry about that. Chronotropy is increase heart rate. I'm getting ahead of myself. And negative chronotropy is to decrease the force of contraction. Well, this is something that ACE inhibitors do not do. What drug does this are the calcium channel blockers. The calcium channel blockers are going to have a negative chronotropic effect, as well as a negative inotropic effect, but it's not going to be something that is a characteristic of your ACE inhibitors. Okay, so it's just A and letter B. All right, let's go to another poll. A 65-year-old is prescribed an ACE inhibitor. What medication is he taking? Excellent. All right. So the reason that we chose letter B is because it ends with a pril. And as we had indicated earlier, anything that ends with a pril or a suffix of pril indicates that this medication is a ACE inhibitor. Excellent. Okay, so the recommendations of the American Heart Association and the American College of Cardiology is to have this as a, what do you call that? A recommended treatment or initial therapy that is for adults with elevated blood pressure. So the other classes of drugs, in addition to ACE inhibitors, are calcium channel blockers, thiazide diuretics, and angiotensin receptor blockers, which are useful as an initial therapy for general block population. So if you're non-block, you're going to be responsive to all these medications. Now, only thiazide and calcium channel blockers are actually recommended as initial therapy for the general block population. This is according to the American Heart Association and the American College of Cardiology recommendations as far as the initial treatment for hypertension. Okay, so remember this because it has come out in the NCLEX before that Black population will respond better to thiazide diuretics and calcium channel blockers. Okay, so the non-Black population are going to have ACE inhibitors as going to be the first drug of choice for the management of hypertension, or calcium channel blockers, or thiazide diuretics, and angiotensin receptor blockers. Now, in addition to hypertension, ACE inhibitors is also used in patients with heart failure. It actually is a strong recommendation as a first choice therapy in patients with heart failure. So why is that? Well, ACE inhibitors are going to improve heart failure by decreasing afterload, decreasing preload and systolic wall stress, which are which results in an increase in cardiac output without any increase in heart rate. And I think we talk about the definitions of afterload, preload, and of course the systolic wall press yesterday. But nonetheless, I'm just going to talk a little bit about preload and afterload, because this is oftentimes confusing. So think about the amount of volume of blood that is going to fill the ventricles is preload, okay? And afterload is the resistance against the advance or the ejection of this volume. So let's say now that your blood vessels are this narrow. Compare that now if your blood vessels are going to be this big. So A versus B. Which one is going to have a lesser resistance? Letter B is going to have a lesser resistance. So we call this a decrease in afterload. So it becomes easier for the heart, therefore, to discharge or empty its contents. When you have an increase in afterload, such as what happens when you have hypertension, for example, the heart has to work extra hard in order to pump blood against this vasculature. So that's the difference between preload and afterload. All right, so in essence then, when we use this on heart failure patients, there's going to be an improvement because there's going to be an increase in cardiac output without having to increase heart rate. Because if you increase heart rate, you also increase myocardial demand for oxygen. All right, the other uses of ACE inhibitors are for post-myocardial infarction. Trials and experiments have shown that giving patients ACE inhibitors decreases the mortality and actually slows the progression of a congestive heart failure after myocardial infarction. And that is the reason why we use it post-myocardial infarction. The other use is in patients with diabetes. So why is it that it is going to be useful in patients with diabetes? Well, the renin-angiotensin-aldosterone system and increased glomerular capillary pressure increases the progression of renal dysfunction due to diabetic nephropathy. So when you give ACE inhibitors, you slow down the progression of nephropathy in patients with diabetes mellitus. So this is always going to be a treatment of choice for patients who have hypertension and also who have diabetes, because they can be useful in both cases. Other indications would be on nephrotic syndrome or proteinuria. Well, this is because it decreases the glomerular capillary pressure and dilating the efferent arterioles of the kidneys. And therefore, this is going to be very useful for them. As well as in chronic kidney disease, because it decreases proteinuria. And of course, anytime there are other diseases of the kidney, such as post-transplantation, for example, or glomerular disease. And what it does is it decreases or slows down the decline in glomerular filtration rate. Okay, so in summary, ACE inhibitors are useful for number 1, hypertension, number 2, for heart failure, number 3, post-MI, and number 4, for diabetes to slow down the progression of nephropathy. All the others are not as common, like the nephrotic syndrome, chronic kidney disease, or glomerular disease, and post-transplantation glomerulonephritis. Okay? All right. So let's go to this next poll. Okay, good. So let's discuss. The correct answers here are the following. It decreases systemic vascular resistance and blood pressure. That is good. And that's the reason why, obviously, we use it as an antihypertensive agent. So letter A is correct. It causes constriction of blood vessels. Well, if it constricts blood vessels, then it would increase blood pressure. So this is incorrect. Kidneys will excrete more water and sodium. Yes, that is correct. That's one of the actions of ACE inhibitors. Kidneys will retain potassium. You remember when you excrete sodium, it's gonna cause the opposite effect. And that is why I want you to remember that when you use ACE inhibitors, it will increase your potassium levels. So you have to watch for hyperkalemia whenever you are giving ACE inhibitors. So do you remember, Jan, the action of aldosterone? If you remember, aldosterone does two things. One, it reabsorbs sodium and water, but it also excretes potassium. Okay, so if you stop this, what's going to happen? You're going to have excretion of sodium and water, and you will have reabsorption of potassium. So that's the reason why letter D is a correct response. So the correct answers are A, C, and D. And of course, letter E is opposite of A, so we can eliminate that. Okay? All right. So let's go to the next one. Okay, very good. Yes, it's going to be very effective in patients with hypertension, also with systolic dysfunction, heart failure. And of course, this is going to be the correct response. Renal failure, yes, but not, again, as I said, it's much more commonly used in patients with heart failure. All right. So let's take a look at the contraindications for the use of this drug. Well, the contraindications for the use of ACE inhibitors are those with a history of angioedema or severe allergic response or hypersensitivity related to the treatment with ACE. And sometimes there are people actually who have hereditary angioedema, and so these individuals should not be given ACE inhibitors. These drugs should not be given also to patients already taking another drug that inhibits the RAS or renin-angiotensin-aldosterone system. An example of that is there's a direct renin inhibitor. This is aliskiren, and that's the one that we would not use it with, okay? And the other one is, of course, avoid in patients who are taking potassium-sparing diuretics, because you remember that what it does, it increases potassium levels. So an example of a potassium-sparing diuretic would be spironolactone. Okay, and ACE inhibitors should not be given during pregnancy. Now, Jen, what I advise you is that anytime you see a contraindication, if it is pregnancy, it's most likely to be a correct answer, because like, for example, this medication, this is a category D in pregnancy because it is known to cause interrupt the scalp formation of the fetus. And therefore, this is going to be avoided in patients who are pregnant. All right, so the precautions or the side effects that we have to talk about are your dry, non-productive, and paroxysmal cough. And there's no treatment for the cough, all right? So this is going to be something that's bothersome. And so sometimes what happens is that we would have to change the medication because patients might be bothered by the non-productive cough. However, the non-productive cough is not going to be something that is going to be serious. It actually is not serious. It's just a side effect, although it's bothersome for patients because of the fact that it might have paroxysmal coughs. It may also cause hypotension, obviously, because of the fact that there's vasodilation, and because of the fact that you are reabsorbing potassium, ACE inhibitors are going to cause hyperkalemia. So you need to be very mindful to monitor the serum potassium levels. Another thing that is something that some patients complain about is that it has a metallic taste, and it alters the taste buds of the patient. And actually, even after you discontinue it, patients still will say that they have an impaired taste mechanism. And so this is going to be another problem that we need to monitor. It could also cause renal impairment, and therefore we need to always evaluate the serum creatinine levels. And of course, again, it needs to be avoided in pregnancy. Now, there is an acronym that has been proposed that one of the ACE inhibitor drugs is known as Captopril, could be a clue for you to remember the important things about ACE inhibitors. So Captopril, spelled C, would stand for cough. So remember the cough. A would stand for angioedema. P, pregnancy problems, meaning to say that it's contraindicated in pregnancy. And T for taste changes. O, other, like rash and fatigue. P for proteinuria, renal insufficiency for R. I, increased potassium, and L for low blood pressure. Okay, so that's just a memory aid for you to remember the most important things about ACE inhibitors. So remember Captopril. Okay, all right. Patient complains of annoying persistent dry cough after taking an ACE inhibitor. What is the nurse's best response? All right, very good. Yes. Reassure the patient that this is a harmless effect. Okay. All right, so that ends the discussion on ACE inhibitors. So we'll now go to ARBs. But just so that we have a fresh information about ARBs, I'm now going to review again the renin-angiotensin-aldosterone system. So it begins with a decrease in blood pressure. And because of this decrease in blood pressure, there's going to be sympathetic stimulation, and this is going to be sensed by the JG cells of the kidney, and it results in the release of a substance called renin. Angiotensinogen, which is present in the angiotensinogen, which is present in the liver, will now activate its angiotensin 1, and this circulates into the lungs, and in the lungs, ACE is going to be released, and this converts angiotensin 1 to angiotensin 2. And angiotensin 2 has two effects. One, it causes the release of aldosterone from the adrenal gland, and the other is going to be vasoconstriction. So both mechanisms are going to do the following: aldosterone, sodium, and water reabsorption. And then, of course, there's going to potassium excretion. So this will result in an increase in blood pressure. Vasoconstriction will also result in increase in blood pressure. All right. So this is now the drug that we are going to be talking about. We are now giving a drug that interrupts angiotensin 2. So notice, if you interrupt angiotensin 2, aldosterone is no longer released, and therefore there's going to be an increase in the elimination of water as well as sodium. So the actions would be elimination of sodium and water, and there's going to be vasodilation, and potassium is going to be reabsorbed. So this basically will now be the main effects of your administration of angiotensin 2. Okay, so going back to the slide then, angiotensin 2 receptor blockers are going to block angiotensin 2 to type 1 receptors, and primarily affects vascular smooth muscle. It blocks vasoconstriction, and it blocks the secretion of aldosterone. So when we block the secretion of aldosterone, we prevent sodium and water reabsorption, we decrease the blood volume, therefore, and we decrease preload. So those are the major effects of ARB inhibitors. So when we talk about ARBs, angiotensin receptor blockers, These medications are those that end with the suffix sartan. So like candesartan, valsartan, irbesartan, losartan, and all these medications are oral medications. Okay. Very good. Okay, the correct answer is letter A. ARBs, angiotensin receptor blockers, prevent angiotensin 2 type 1 receptors from binding with angiotensin 2. So remember that ACE inhibitors inhibit angiotensin converting enzyme from converting angiotensin 1 to angiotensin 2. Okay, so that's the difference. All right, great. All right, so you remember that sartans are going to be your ARBs or angiotensin 2 receptor blockers. Excellent. Okay, so what are the indications of angiotensin receptor blockers? Well, basically, again, for hypertension, as well as for diabetic nephropathy and heart failure. So it's similar to the uses of ACE inhibitors. Okay, so ARBs are going to be similar to the action of ACE inhibitors. Both of them, ARBs and ACE inhibitors, decrease the blood pressure, which therefore will decrease the amount of protein in the urine. And this will also help, therefore, delay the progression of renal disease, particularly in patients with type 2 diabetes. So the use in heart failure, it makes it easier for the heart actually to pump because of the decrease in afterload and the decrease in preload. Okay? All right. So what are the side effects? The most common side effects are mild and non-specific, and they might include like headache, dizziness, drowsiness. They also have been, of course, associated with the development of angioedema, and it could also cause, of course, postural hypotension, as well as tachycardia. And of course, the other thing that needs to be remembered is that because ARB interrupts with aldosterone, what's going to happen is you're going to have a hyperkalemia. So remember, hyperkalemia is a very common side effect of the drug. And again, it's contraindicated in patients who are pregnant. So similar to Captopril for ACE inhibitors, people have said that in order to memorize or to remember ARBs, angiotensin receptor blockers, you need to think of losartan. And the L will stand for low blood pressure. O for other signs and symptoms like fatigue and dizziness. S for swelling, allergic reaction, raised potassium. It's teratogenic. It's useful for acute kidney injury and nasal congestion. So those are some the ways in which you could remember the side effects of ARB inhibitors. So Captopril for ACE and losartan for ARBs, or angiotensin receptor 2 blockers. Okay. So, Jan, do you remember it reabsorbs, aldosterone excretes potassium and saves sodium and water. So when you block angiotensin receptors, what you're going to do is to cause the opposite. You will develop hyperkalemia. Okay, not hypo, hyper. All right, so remember that. So the correct answer is hyperkalemia, letter D. Okay, so what are the pharmacodynamic effects of angiotensin 2 blockers? Select all that apply. All right, so it certainly will cause vasodilation because it interrupts with the vasoconstricting effects of angiotensin 2 receptors. And so what's going to happen is that you will have sodium and water excretion, and what happens to your potassium? Potassium is conserved. So it does not cause vasoconstriction. Sodium conservation, and it eliminates the sodium, isn't it? And also eliminates the water. And therefore, there will be water excretion. Okay? Water excretion. So let's go back to the action of angiotensin receptor blocker, ARBs. Okay. So angiotensin 1 is converted to angiotensin 2, right? And angiotensin 2 causes the release of aldosterone. And remember the two actions of aldosterone. One is to reabsorb sodium and water. And number two, it excretes or secretes potassium. Okay? And the other one is vasoconstriction. So if you block angiotensin 2, you're going to eliminate water, you're going to reabsorb potassium, and you're going to have vasodilation. Okay? So remember these actions of aldosterone. All right, so what are the responsibilities of the nurse as far as angiotensin receptor blockers are concerned? Well, make sure that we always monitor potassium. Why? Because ARBs, like ACE inhibitors, can cause hyperkalemia. You also need to monitor the BUN and creatinine because patients might have an elevation in BUN and creatinine which could cause renal failure, caused by renal failure. And then, of course, liver enzymes are going to be watched because patients are at risk for liver failure. Anytime you use a medication, because the liver is the primary metabolic agent to eliminate or process drugs, you always have to take that into consideration, right? And of course, always make sure that when you are dealing with hyperkalemia, in this case, this is the possible complication, what are the nursing interventions for hyperkalemia? Well, the nursing interventions for hyperkalemia are going to include the low potassium diet. And then, of course, the other thing is that no salt substitutes. The reason why there's this particular warning, no salt substitutes, because salt substitutes are actually potassium chloride. See, when we use salt, it's sodium chloride, but when we use salt substitutes, it's potassium chloride. So therefore, this should be avoided, okay? And avoid potassium high foods. The foods that are high in potassium are mainly potato, particularly the peeling of the potato. And then, of course, your banana as well as oranges. So those are the important food items to avoid. So we finish with ACE inhibitors and we finish angiotensin receptor blockers. So now we're going to talk about beta blockers. And beta blockers are something that influences or alters the autonomic nervous system. So what do I mean by that? So let's go back to the autonomic nervous system. When we talk about the autonomic nervous system, we actually talk about two systems, the sympathetic and the parasympathetic nervous system. So let me just draw something here. Okay. So one of the functions of the sympathetic nervous system and the parasympathetic nervous system is, of course, its effect on the heart, as well as the cardiovascular system. So this is the autonomic nervous system. And the autonomic nervous system consists of the sympathetic and the parasympathetic. This is the fight or flight or stress response. And this is the rest and restore response. Okay, so the sympathetic nervous system actually acts by way of a hormone, and this hormone is what is known as norepinephrine. And if it is released, what does norepinephrine do? Well, it does a lot of things. And one of them would be vasoconstriction, an increase in heart rate, and so on and so forth. So that's the reason why whenever you give adrenaline or norepinephrine, you will see an increase in blood pressure. So the other name for epinephrine is adrenaline, and that's why this particular part of the autonomic nervous system is often referred to as the adrenergic system. All right, the parasympathetic nervous system, on the other hand, is influenced also by another chemical, and this particular neurochemical is going to be acetylcholine. And oftentimes it is referred to as ACH. And that's the reason why this part of the autonomic nervous system is known as the cholinergic system from acetylcholine. Okay, so now we're going to be studying this particular thing now. And I'm now going to go to another black screen to tell you a little bit about the sympathetic nervous system. When epinephrine is released by the adrenal gland, what's going to happen is that it is going to circulate into the body looking for receptors. So there are several receptors that welcomes norepinephrine. One such receptor is what is called alpha receptors. The other receptors are what's called beta receptors, and the other one is what's called dopaminergic receptors. Okay, so you're circulating norepinephrine, and it now circulates in the body. It just happens that alpha receptors are abundant in the heart. I mean, in the blood vessels, I'm sorry. And this particular type of receptor is called alpha-1 receptor. So this is abundant in the heart. I mean, in the blood vessels, sorry. All right, so this is abundant in the blood vessels. And so when epinephrine or norepinephrine enters into alpha-1 receptors, it causes vasoconstriction. So therefore, it elevates blood pressure. Okay. So there's another kind of receptor that is alpha receptor type 2, but these are found mainly in the central nervous system, so we're not going to talk much about that. All right, so epinephrine further circulates in the body, and it also can enter into another door or doors, and these are called beta receptors. And there are also two types of beta receptors, beta 1, and the other one is beta 2. Beta 1 is abundant in the heart, and beta 2 is abundant in the lungs. So it's easy to remember because we have one heart and two lungs. So beta 1 is more abundant in the heart, and beta 2 is in the lungs. So what does epinephrine do in the heart? Well, it does several things. One is it increases heart rate, and this is what's called chronotropy or positive chronotropic effect. The other action is that it increases the force of contraction. And this is known as the positive inotropic effect. All right. And in the lungs, its action is it causes bronchodilation. Okay, so in summary, when epinephrine is released by the adrenal glands, it circulates that it may enter into alpha doors, and alpha doors are of two kinds, alpha 1 and alpha 2. Alpha 1 receptors are abundant in the vascular bed or smooth muscles, and alpha 2 is abundant in central nervous system. So this is the neurotransmitters, if you remember, in psych. Now, it could also enter doors marked beta, and beta are of two kinds, beta 1 and beta 2. And beta 1 is abundant in the heart, and when it enters into beta 1 receptors, it causes an increase in heart rate, which is chronotropy. It increases the force of contraction, which is inotropy. And I also should add domography, which is an increase in AV conduction. Okay, so these are the effects of norepinephrine on these receptors. And the last receptors are the dopa receptors or dopamine receptors. And the dopamine receptors are going to be more abundant in your kidney, for example. So when it does go into the kidney, it causes an increase in the circulation in the kidney or renal perfusion. So these are the effects of the epinephrine. So again, there are several types of receptors. Alpha-1 receptors located in vascular walls. Now, this causes vasoconstriction of the peripheral blood vessels, and therefore it will increase blood pressure. Beta-1 receptors are found in the heart, and it could cause positive inotropy, as well as chronotropy and dermography. That's AV conduction. And of course, in beta-2, its action is going to be in the lungs, and it causes bronchodilation and vasodilation of those blood vessels in the lungs. And the dopaminergic receptors are found mainly in the renal, as well as mesenteric and the cerebrovascular beds. And they cause vasodilation as well, vasodilation. Okay, so those are the receptors as far as the sympathetic nervous system. So what is the relationship to beta blockers? Well, beta blockers, therefore, are drugs that would block these two. So if you block these two, what's going to happen? You will have vasodilation. And if you block beta-2, you will have bronchoconstriction. Okay? And that is the reason why we have drugs nowadays that only will block beta-1 and not beta-2. So if they block only beta-1, we call this cardioselective. It only blocks the effect in the heart. All right, so how do you know that beta blockers are going to be the drug that you're dealing with? Well, because they all are going to end with the suffix olol, O-L-O-L. So whenever you see a drug that ends with the suffix olol, like labetalol, sotalol, and others, then that means to say that this is a beta blocker. Okay? All right. Let's go to this poll. Sorry about that. It was moving. I'm moving something else right there. Welcome, Shuntavia, by the way. Okay, so we did not talk much about the other areas that are responsive to beta-1. So I'm now going to tell you what the correct answers are. Well, it's also found in the uterus, and that's why you might be hearing that sometimes it is used in in obstetrics. It is also, of course, abundant in the heart, as well as the vascular smooth muscles and the kidneys. So all these actually are going to be where beta-1 receptors are. But I only emphasize actually the location of in the heart. Okay, so right here, beta-1 receptors are going to be located in the heart. That's what I emphasize, right? All right, so what's the mode of action or the mechanism of action of beta blockers and how they affect the body? So again, they block sympathetic nervous system stimulation. So when you block sympathetic nervous system stimulation, you're actually, in essence, blocking the entry of norepinephrine into alpha, beta, and dopaminergic receptors. So the end result, therefore, would be that there will be a negative chronotropy, meaning to say that there will be a decrease in heart rate. It slows down conduction velocity in the AV node, and it also causes negative inotropy. So which means to say that you have a decrease in the force of contraction. So one important thing, if you decrease the force of cardiac contraction, you would require less oxygen. And that is the reason why it is a very good drug for patients that have had a myocardial infarction in order to decrease cardiac demand. Now, the other thing is that, of course, it decreases blood pressure. And that is the reason why we are actually discussing this along with the other antihypertensives. And it could also be found in patients who have had eye surgery, for example, or conditions with increased intraocular pressure, such as in glaucoma. So what it does is it decreases intraocular pressures. Okay, so there are other obviously actions of beta blockers, but these are the most common mechanisms of action pertaining to the treatment of hypertension and cardiovascular disease. So as you could see, it's indicated in angina, in MI. It is also indicated in cardiac arrhythmias, as well as hypertension and heart failure. And the other minor uses are, of course, to treat migraine headaches, glaucoma, and also thyrotoxicosis. Because you remember, in hyperthyroidism, there's going to be tachycardia, and therefore, if you decrease the tachycardia, this usually is going to help the patient manage the symptoms. Okay, so these are the cardiovascular uses of the medication, but it could also be used for migraine, glaucoma, as well as in thyrotoxicosis. The drug that is very common in glaucoma is going to be timolol. Okay, so this is going to be a frequent question in the NCLEX. If you are giving a drug that is going to be a non-selective beta blocker, it affects both beta-1 and beta-2. So, which means to say that you could cause bronchoconstriction. So if you're using a non-selective beta blocker, it is contraindicated in patients that are going to have lung disease. However, there are now drugs that are cardioselective. So any beta blocker from A to N are all cardioselective. Please remember that. So acetabutalol all the way to metoprolol and nebivolol are beta blockers that are cardioselective. When I say cardioselective, They only block beta 1, not beta 2. So these drugs, therefore, are going to be safe for patients who have history of COPD or other lung disease. However, beta blockers that starts from O to Z are non-selective, meaning to say that they're going to block beta 1 as well as beta 2. Thus, when you use these drugs, it is contraindicated in pulmonary disease. Okay, so the drug betaxolol is going to be cardioselective because any beta blocker from A to N are going to be cardioselective. O to Z are going to be non-cardioselective, which means to say that they block beta 1 and beta 2. This one only blocks beta 1. Okay. Yeah, I already said something about this one. Okay, so what are the complications or the precautions, I should say, in the use of beta blockers? Well, the precautions is inclusive of a black box warning. And let me explain black box warning. Anytime there's a black box warning, you are supposed to remember that. So a black box warning for beta blockers is that it cannot be withdrawn abruptly. It's got to be withdrawn and a decreasing dose, and it should be gradual. Okay, so that's number one. So anytime there's a black box warning, always remember that, because that is the most important thing that you need to know about that drug. Okay, so the other precautions are that it is contraindicated in heart failure. Why is that? Because you remember, it causes a decrease in the force of cardiac contraction. So therefore, if you give it to patients with heart failure, they're going to have an exacerbation of the symptoms. The other thing is that it's also contraindicated in Raynaud's disease. Now, one other thing is that these patients may experience depression and impotence, as well as constipation. So let's talk about impotence. Now, there has been a question in the NCLEX in the past wherein the question asked for what would be the best antihypertensive for a 35-year-old male. Well, remember that we do not prescribe medications of beta blockers to young men because it causes erectile dysfunction. So always remember that, not for young men, all right? And of course, because it stops sympathetic stimulation, it usually is going to cause or actually mask the symptoms of hypoglycemia. So remember that in hypoglycemia, patients oftentimes will feel weak, as well as they would develop tachycardia. So this might be the only sign, therefore, that you would have to rely on, that the patient is having hypoglycemia whenever a patient is taking beta blockers. Now, in addition to those, it might increase triglycerides and lower down your good cholesterol. And of course, if in non-selective beta blockers, it could cause bronchospasm, because if you're going to block beta 2, then you're going to cause bronchoconstriction. And lastly, the other nursing intervention here is to make sure that you monitor the patient's weight. Because of the decrease in the force of cardiac contraction, the patient might develop heart failure. And the first signs of heart failure may be weight gain, a weight gain of 2 pounds in 24 hours or 5 pounds in a week. is going to be significant and therefore should be reported. Okay. All right. So similar to the other drugs that I have discussed, the way in which you try to remember beta block precautions or blocker precautions is to think of beta block. Okay. So B is for bradycardia, which obviously is an effect of beta blockers. E, it could exacerbate heart failure. T, taper off. You remember the black box warning. A, no for asthma and COPD. B, always check the blood glucose because it masks the signs and symptoms of hypoglycemia. It decreases blood pressure because of the fact that it causes vasodilation. It could cause orthostatic hypotension. It could cause impairment of the circulation. And of course, no overdose signs and symptoms. So those are the ways in which you could remember beta blockers. So let's now go to another poll. Very good. The correct answer is going to be letter A. Okay. Propranolol is O to N to Z. So therefore, this is a non-selective beta blocker. It affects both beta 1 and beta 2 receptors. And as we said, beta 2 receptors are found in the lungs. And this medication, therefore, could cause bronchoconstriction, which could cause a worsening of the asthma or COPD. Okay, great. Very good. Excellent. So as we said, the answers are B, C, and D. Metoprolol, atenolol, and esmolol are selective, and they only affect beta 1 receptors, which are found in the heart as well as in the kidneys. So, and D. Okay. All right, so we finished ACE inhibitors. We finished angiotensin receptor blockers. We finished beta blockers, and now we're going to talk about calcium channel blockers. And this is going to be the last part of our presentation today. All right, so calcium channel blockers are other antihypertensive drugs. And whenever we are looking at drug names, the suffix dipene is the one common denominator to identify that it's a calcium channel blocker, right? Dipene. So how do these calcium channel blockers work? Well, in order to produce contraction, what happens is calcium is going to be released into the sarcoplasmic reticulum. And what happens when calcium enters into the vasculature is it causes vasoconstriction because it constricts or contracts smooth muscles. Now, whenever we block this effect, then we get the opposite. When we have calcium channel blockers, we therefore dilate the arteries, And we therefore reduce blood pressure and decrease peripheral resistance. So we dilate the blood vessels, we decrease the blood pressure, and we also decrease the peripheral vascular resistance or afterload. So when you dilate it and when you decrease vascular resistance, you're now going to obviously reduce the oxygen demand of the heart. So those are the things that you need to remember as far as actions are concerned of these medications. They're going to dilate the coronary arteries as well. So this is going to be good or be beneficial for those patients who have coronary artery disease. And so these are some of the effects. Now, if you decrease the contraction of the smooth muscles, so that leads to vasodilation. If you are going to decrease the force of contraction, then this is going to be called a negative inotropic effect. So calcium is a negative inotropic agent because it decreases the force of cardiac contraction. So I'm emphasizing that because in the treatment or even in the side effects, we're going to deduce that a problem that might occur would be heart failure, okay? So the mechanism of action, as I said, is going to be that it blocks the entry of calcium into the cells. It causes negative inotropy, which means to say that there's going to be a lesser contraction of both the blood vessels as well as cardiac muscle. It's going to cause negative dromotropic effect, meaning to say that it's going to decrease the transmission of electrical impulses from the SA to the AV node. It causes vasodilation, and of course, it decreases peripheral vascular resistance. So you could deduce that it's going to be very useful for patients with angina as well as hypertension. So these are the two main ways in which we are going to use these particular drugs. Hold on one moment. Let me just, okay. Now, it's also going to be very useful, therefore, if it decreases the firing potential of the sinus node and decreases the conduction to the AV node, then this is going to be useful for supraventricular tachycardia, as well as atrial fibrillation and flutter when there is an increase in or rapid ventricular response. So the other uses are going to be migraine, Raynaud's disease, and cerebral artery spasms, in particular, nimodipine. So these are the things that calcium channel blockers are going to be useful. And they propose that you can remember the uses of calcium channel blockers by remembering CHASMA. And CHASMA stands for cerebral vasospasm, hypertension, angina, supraventricular tachycardia, migraines, and atrial flutter and atrial fibrillation. Okay. Any response? Okay, great. All right. So let's take a look at the options here. We're looking at a lot of understanding. So a patient with diabetes type 2 and hypertension is prescribed sotalol, which is a beta blocker, and insulin. So this medication can affect my blood glucose levels. We said that it does, doesn't it? It also masks the signs and symptoms of hypoglycemia. I will monitor my pulse and BP every day. Yes, this would be a good intervention because it decreases the pulse rate as well as it decreases the blood pressure. And I will monitor for fast heart rate, a sign of hypoglycemia. Well, this is true, but remember that beta blockers are going to decrease heart rate. And therefore, this is no longer going to be a reliable sign for monitoring for hypoglycemia. So you might have to monitor for other signs and symptoms of hypoglycemia. And I will report weight gain or swelling in my feet. This is correct because of the fact that a problem with the use of beta blockers might be weight gain. So letter D is the correct response. So this is the one that's incorrect, which denotes lack of understanding. Okay. Let's go to the next one. All right. So it should all be negative. All right. So it causes negative inotropism, meaning to say a decrease in the force of contraction. It could also cause a decrease in heart rate, and that's why it's useful for the management of tachycardia. And you remember it slows down sinus node as well as AV node conduction, and that is the reason why it would be useful for patients who have SVT. Okay, so it should all be negative. Negative inotropic effect, negative chronotropic effect, and negative dromotropic effect. Now, most calcium channel blockers are going to end with dipene. As you could see over here, amlodipine, pilodipine, isradipine, nicardipine, and nifedipine. While there's another type of calcium channel blockers, another family, and they're called the non-dihydropines. And these non-hydropyridines are going to be the ones that are more action on the myocardium. So, for example, verapamil, which is Kalen, as well as diltiazem, which is cardizem, are both drugs that are calcium channel blockers, but they're mainly used to manage tachycardia because it is more myocardium selective. Okay, so in addition to dipene as an ending, you need to remember that verapamil and diltiazem are going to be non-dihydropyridines. Okay? All right, so what are the side effects of calcium channel blockers? Well, the most common is going to be headache, actually, as well as peripheral edema. So those are the two most common side effects are headache as well as peripheral edema. Obviously, if it's an antihypertensive medication, it's going to cause hypotension. And for the non-dihydropyridines, the most common side effects are going to be bradycardia as well as constipation. So those are the common side effects. Another side effect that we need to remember is that because it slows down cardiac conduction to the AV node, it may be manifested in the ECG with occurrence of heart block. So anytime you see P waves that do not have QRS complexes, you always think of a heart block. So this is a P wave, for example, that does not have a P wave. And therefore, anytime you see that, you always say that there is heart block. So in this particular case, this is a second-degree AV block type 2. But don't be concerned about that. The most important thing is anytime you see a P wave without a QRS complex, the answer to that ECG rhythm should be an AV block. Okay? All right, there are some precautions that are going to be observed in calcium channel blockers. Now, in the old days, and unfortunately in other countries they still do, they usually give sublingual nifedipine to patients who are having severe elevations of blood pressure or blood pressure crisis, hypertensive crisis. This has been discovered to cause a lot of deaths, and therefore it is not an accepted practice at all. So no to sublingual use for hypertension emergency. Now, in the area of labor and delivery, it also is given to patients with premature labor. But I want to just emphasize and not discuss in detail that, but they emphasize that whenever it is used for premature labor, it usually comes from the pharmacy in a syringe. And therefore, this particular practice is to prevent you from giving it IV because it should only be given PO. Cardicem SR and Cardicem CD is going to be sound-alike medications. They are different. Your SR is slow release and CD is different, and therefore it should be remembered that they are sound-alike medications, but they're different. And lastly, anytime you are giving medications, you should always tell the patient never to drink grapefruit juice. And the reason why grapefruit is going to be contraindicated in any of these medications is because it reduces the metabolism and the elimination of those drugs. And so that is a general caution. And the nursing implications, make sure that you monitor the patient's heart rate and blood pressure, watch for orthostatic hypotension, monitor for heart failure, and of course, there's going to be a problem with constipation, and so measures to prevent it has to be undertaken. And this is the last one. Okay, excellent. You certainly don't want to give it in a case of third-degree heart block and also with a slow heart rate. Well, we would give it for patients with a blood pressure of 192/102, and also for patients with atrial fib, particularly with rapid response. I want to thank you, Jan and Shantavia, for participating this evening. And I hope that you were able to gain some information that would be used for your NCLEX. And I look forward to having you again tomorrow. Tomorrow, we will have further discussions on more drugs, and it will include respiratory drugs. There are other cardiovascular drugs as well as pulmonary drugs. Okay, so I'm going to see if you have any questions. If you don't have any questions, you're welcome to log out. And I want to say thank you and have a good evening. Thank you. See you tomorrow. Yes.